Okay, thank you for the opportunity to present. My name is Johan Hardvik Åkerström, and I'm joining you from the Karolinska Institute in Stockholm, Sweden. And I've been asked to talk about our 2024 study, Antireflux surgery versus antireflux medication and risk of esophageal adenocarcinoma in patients with Barrett's esophagus. And esophageal cancer is the seventh most common cause of cancer-related mortality. The 5-year survival is still only about 20%. There are two main histological types of this cancer, squamous cell carcinoma and adenocarcinoma. And esophageal adenocarcinoma is the most common of the two in Western countries. Esophageal adenocarcinoma has had an increasing incidence in many Western countries. It was rapidly from the 1970s until the early 2000s, and it has been more gradually since then. Uh, the most important risk factor for this cancer is gastroesophageal reflux disease. And gastroesophageal reflux disease is defined as troublesome symptoms from gastric contents reaching the esophagus or complications from gastric contents reaching the esophagus. And weekly symptoms of reflux have been associated with an odds ratio of more than 4 for esophageal adenocarcinoma. The complications caused by this acidic reflux state are esophagitis and inflammation of the esophageal mucosa, esophageal peptic strictures when the inflammation results in fibrotic scarring, and then Barrett's esophagus, a metaplasia of the normal squamous epithelium to a columnar epithelium. And again, Barrett's esophagus is when columnar mucosa replaces the reflux-damaged squamous mucosa in the distal esophagus. This, importantly, is a precancerous lesion, and it has a prevalence of 1 to 2% in Western populations. The annual risk of progression to cancer is about 0.2 to 7%. And these patients with Barrett's esophagus are a high-risk group that is enrolled in endoscopic surveillance programs, and they are suitable. This group of patients is suitable for cancer preventative actions, I should say. So, the recommendation is to use proton pump inhibitors for these patients with Barrett's to reduce the risk of progression to adenocarcinoma. However, if this actually decreases the risk of progression to cancer is uncertain. But there are alternatives. Anti-reflux surgery with fundoplication is the most common anti-reflux surgical procedure. During the procedure, the fundus of the stomach is wrapped around the distal esophagus, and you see an illustration of that there. Uh, this decreases the amount of gastric contents reaching the esophagus. And anti-reflux surgery may have a greater cancer preventive effect than anti-reflux medication because of the greater reduction in esophageal acid exposure and because it prevents any carcinogenic gastric contents from reaching the esophagus. That's including both acid and bile. Bile acids, which may also contribute to the pathogenesis of esophageal adenocarcinoma. And previous studies have not been able to consistently demonstrate a larger cancer preventive effect of anti-reflux surgery compared to anti-reflux medication. However, these studies have often been have had a small sample size, had a short follow-up, and the samples have also often been selected. So the aim of this study was thereby to examine the hypothesis that anti-reflux surgery decreases the risk of esophageal adenocarcinoma more than anti-reflux medication in patients with Barrett's. And we wanted to conduct a large study of an unselected cohort with a long and complete follow-up. So this study was a population-based cohort study with information from nationwide health data registries in Denmark, Finland, Norway, and Sweden. The study period spanned from 1987 to 2020, but it varied between the individual countries due to data availability. And our data sources were the national patient registries, cancer registries, prescribed drug registries, population registries, and the cause of death registries in these countries. All these registries contain prospectively collected data and are kept mainly for administrative purposes. Uh, the personal identity codes, which each Nordic resident is assigned at birth or immigration, it enables linkages of individuals' data between these registries. The cohort was made up of adults with the Barrett's esophagus diagnosis. These diagnoses were identified in the patient registries. The exposure was anti-reflux surgery with fundoplication, also recorded in the patient registries. The comparison group was made up of Barrett's patients on anti-reflux medication, not surgery, anti-reflux medication. This was identified in the prescribed drug registries. We used a validation study for that. And the outcome was esophageal adenocarcinoma identified in the cancer registries. So, non-operated patients using anti-reflux medication contributed unexposed person time from the date of diagnosis of Barrett's until the date of esophageal cancer, death, esophagectomy, end of study period, or anti-reflux surgery, whichever came first. And patients who underwent anti-reflux surgery contributed exposed person time from the date of surgery until the date of esophageal cancer, death, esophagectomy, or end of study period, whichever occurred first. Patients initially included in the non-operated group could thus cross over and contribute person time to the anti-reflux surgery group from the date of surgery. And we used Cox regression, providing hazard ratios with 95% confidence intervals. And we used a model adjusted for age, sex, country, calendar year, and comorbidity. So, this cohort included almost 34,000 patients with Barrett's esophagus, as you can see. And the overall risk for esophageal adenocarcinoma was in fact not decreased among patients that had undergone anti-reflux surgery, as we might have been expected or as might have been expected. Instead, the adjusted hazard ratios were increased in the surgery group compared to the medication group, as you can see. And also, these hazard ratios tended to increase in the surgery group for each follow-up period. Okay, so it doesn't look like anti-reflux surgery, at least in this study, had a protective effect. And this might be due to that fact that anti-reflux surgery is often reserved for patients with the most severe gastroesophageal reflux. And because the risk of cancer increases with reflux symptom severity and duration, it's not surprising that patients selected for anti-reflux surgery had a higher baseline risk of esophageal adenocarcinoma. However, risk estimates did not decrease over time. As you saw, they increased. And this to us suggests that the carcinogenesis had progressed too far to be halted at the typical time of anti-reflux surgery in this observational study. So our conclusions were that anti-reflux surgery does not seem to decrease the risk of esophageal adenocarcinoma more than medical anti-reflux treatment among patients with Barrett's, and that uh, we therefore argue that with the current clinical practice of anti-reflux surgery, often conducted after long periods of persisting reflux, patients should not undergo anti-reflux surgery for cancer preventative reasons alone. And we argue that patients with Barrett's who undergo anti-reflux surgery remain at an increased risk of adenocarcinoma in the esophagus and should continue taking part in endoscopic surveillance programs. Okay, that was it. Thank you so much again for the opportunity to present.